Dave, I think Pramod is going to open up, right? It's 8:30. Let's go.
Yes, let's start, sir.
Good morning, doctors. I am Dr. Mohit Kumar Bargujar, and I welcome you all to ANZAWR 2021. It is going to be an academic feast today, and where we will discuss various aspects of inguinal hernias.
Better to start than with the basics. So let's dive right in without further ado. Let's introduce you to our chairpersons. Dr. Ramana, who's the founder, president, AWRC from CMRI Hospital, Kolkata, India, and Dr. David Waddell, hernia and colorectal surgeon from Geelong, Australia. And now this session has been sponsored by BARD.
Friends and colleagues, it is indeed an honor and my pleasure to welcome you all on behalf of Abdominal Wall Reconstruction Surgeons Community, ANZ Hernia Society, my co-chair David Waddell, secretaries Sharat Sharma, Alex Karatasas, and the entire team of AWR ANZ 2021 to this unique single-theme conference on inguinal hernia. It is said that a journey of 1,000 miles begins with a single step, and just such a step taken less than a year ago has already given us a great conference on AWR a few months back. And I'm sure this AWRSC ANZ Hernia Association is going to take us a long way in the years to come. I take this opportunity to welcome all our international and national faculty across the borders, all our delegates, residents, and sponsors to this August conference. Thank you.
Yeah, thanks, Pramod, and I'd like to thanks just a short thank you to all the organisers, and it's very exciting to have this combined Australia and India collaboration on this conference. I think we'll get going pretty much straight away. So I think our first speaker is Eham Arora. He's a personal friend of mine who I met in Calcutta. He's from Mumbai, though, assistant professor at the Sir J&J Group of Hospitals and Grant Medical College, Mumbai. He's also the director of the Young Turks, which is part of the AWR community. And he's going to talk on anatomy in groin hernia.
Hello everyone, I am Eham Arora and I come to you from Grant Medical College and Sir JJ Group of Hospitals in Mumbai. At the outset, big thank you to the entire organizing team of ANZ AWR 2021 for the opportunity to speak. The task that has been given to me is talking about laparoscopic inguinal anatomy in all of 15 minutes. So if you'll excuse me, I'll talk about what I think is new and interesting in the inguinal anatomy space and where people end up getting confused the most. So why is there a separate session for this? Haven't we really seen all of this before? If you talk about the differences between lap versus open appendectomy, the steps of surgery more or less remain the same. The mesoappendicular division, the division of the appendicular base, and getting the specimen out. The surgeries are almost the same, barring the approach, because the anatomy stays constant. And even in other procedures like a lap pulley, where we have new concepts like the critical view of safety, remember, your viewpoint of the anatomical space has changed, but the anatomy again stays the same. But when you compare lap versus open inguinal hernioplasties, you realize that these are two very, very different surgeries that are essentially aimed at solving the same problem. The picture on your left is the typical view that we get in a laparoscopic space. You can see the cord structure displayed wide apart. You end up seeing the external iliac vessels, and God forbid if you ever see the external iliacs in a Liechtenstein repair, right? A lot of people think about MIS, inguinal hernia repairs, needing relearning of the anatomy from an unfamiliar perspective. I'd like to rephrase that a little. It's more about learning unfamiliar anatomy from an even more unfamiliar perspective. A few decades ago, we had all of these different classification systems for groin hernias. And that was essentially to improve decision-making, because you would have to choose from a limited number of tissue repairs to repair these inguinal cases. And depending on which subtype they belong to, they would benefit from one or the other repair. Over a period of time, we had a bunch of other different surgeries come in. This was, of course, all before the use of mesh in the inguinal space became commonplace. And mesh plasties landed up standardizing a lot of our procedures and took away this decision making. Now we don't classify our hernias as deeply as we did earlier, but we still talk about direct, indirect hernias and femoral hernias. Now, do these anatomical landmarks, spaces, and defects exist in the laparoscopic space? Of course, it's apparent on screen that all of these hernias can be seen even laparoscopically, and indeed you can classify them even with a minimally invasive viewpoint. But now we've come to realize that it's not the subtype of the hernia that essentially matters. It's this entire myopectineal orifice, this purported area of weakness in the antero-inferior abdominal wall that was described by Henri Frouchot, a French anatomist and surgeon. He was of the opinion that there is an area of weakness that does not have any significantly strong fascia or bony structures that are augmenting it. So this area of weakness is where all groin hernias land up originating. And we owe Dr. Frouchot a lot because he has definitely given us the guiding principles for the posterior repairs that we are performing today. This is one place where there exists a lot of confusion, especially in the minds of early trainees, is that a lot of people confuse the iliopubic tract as the posterior view of the inguinal ligament. Now you can see in this cross-sectional diagram over here that just isn't the case. You can appreciate the external oblique aponeurosis muscle going down. It forms the inguinal ligament and this turns backward. But you can appreciate the iliopubic tract is distinct. It essentially stretches between the ASIS and the pubic tubercle, but it's not the same as the inguinal ligament. So you may be able to see a mirror projection of the inguinal ligament when you're doing a posterior repair, but these are two very distinct structures. Of course, you can see a superimposition of the myopectineal orifice is essentially bisected by the iliopubic tract. So you have the direct and the indirect space above it. And below that, you have the femoral space that lies medial to the external iliac vein. I'll just take a few seconds to hit upon the corona mortis just because it sounds so cool, crown of death. It was this cautionary name that was given to one anatomical structure so that people don't go about messing with it. But when you look deeply, it's really nothing that special. What the corona mortis is a sort of portal circulation that exists between the external iliac and the internal iliac vessels. And this little anastomotic communication extends across the pubic ramus, and as you can imagine, can sometimes come in the way when we are performing posterior repairs. I'd like to spend some amount of time talking about the transversalis fascia, or the many faces of the transversalis fascia, as I call it. Since its first description about 2 centuries ago, we have come to define and redefine this anatomical structure over and over again. Let's talk about current concepts with this anatomical structure. So a lot of people are now saying the transversalis fascia is not actually fascia, but it is loose tissue that exists outside of the peritoneal cavity. And this loose areolar or fibrofatty tissue is just randomly organized. If anybody has opened a box containing hay, as we are doing in mango season here in India, you'll realize that the hay forms an almost continuous surface at its interface with the box. And that is essentially what is happening even in the diagram. You can see all of this tissue is loosely arranged, but at its interface with a continuous structure, there's an almost continuous fascia-like condensation. And it is for this reason that a lot of people are now considering the transversalis fascia to be bilaminar with a potential space in the middle. This has indeed been noted by several researchers, and you can see that there exists a fascia that lies superficial to the peritoneum that they have kind of divided and then are able to visualize the rectus muscle. Of course, there are more complex anatomical descriptions of the transversalis fascia. I would highly recommend reading this paper by Dr. Asakaze from Japan. He talks about the different changes in the extraperitoneal tissues that are a consequence of embryonic development with several organ systems involved. And he goes into great depth about the microfascias that exist within the pelvis. I won't go into a lot of depth, but I'll give you a very, very highly, perhaps overly simplified version of what's happening with the fascias. So if you think about the transversalis fascia as bilaminar, there obviously has to be a parietal layer, which is the dotted blue line that you see, and there has to be a visceral layer, which is the solid purple line that you see. The yellow is represents the peritoneum that, of course, is enveloping the urinary bladder posteriorly, and anteriorly we have the pubis. These two red dots are the inferior epigastrics. So the lateral extraperitoneal space is the space of Bovros, but you can exist that there is an other cavity that exists even more superficial to this. The superficial cavity is continuous with the cave of Retzius. Let's go into this in a little more detail. Now, the several compartments that are created as a result of this bilaminar transversalis fascia are very, very apparent in the midline, where you have a parietal layer that is very closely adherent to the muscle and actually is continuous downwards on the posterior surface of the pubis. The more visceral layer of the transversalis fascia lies just superficial to the peritoneum, and it goes down and is quite densely attached to the anterior surface of the bladder. In classic anatomical textbooks, this is actually sometimes been referred to as the prevesical fascia, although some people say that the prevesical fascia only exists between the medial umbilical ligaments. Anyway, you can see that there are two arrowheads pointing into a more superficial space, and then there is a deeper compartment. Let's go back to our cross-sectional diagram. Again, remember, there is a more parietal compartment and there is a visceral compartment. Both of these are essentially extraperitoneal, and it is a visceral compartment that is commonly referred to as the Bovros space. Now, let's take a look at this TAPP video. We are dividing the peritoneum from lateral to medial. And you can see just as we progress medially, there is some fibrous structure that is lying above where the hook has been operating. As we change the traction, the CO2 gets insufflated into a new space. And you can see there is a distinct fascia. We now start entering here. You can see there's extraperitoneal fat. There is a very distinct layer that is almost bisecting the entire area. This is actually the visceral part of the transversalis fascia. So there is a compartment that exists more superficial to it medially, which is being dissected, and there's a compartment that is more viscerally oriented laterally. As we go on, we can land up dividing this fascia towards the deep ring to connect these two spaces. You can see on the medial aspect, the inferior epigastrics are now come really well into view. And if you continue dissecting in this space, you're going to go down and be able to reach the pubis. This is what's happening in the lateral space. So remember, we are laterally more on the visceral side or the inner side. So just light sweeping movements of the tissues will land up exposing or land up visualizing the nerves. The fat, when it is being stretched across, you'll realize is always associated with some fascia that is covering the lateral abdominal wall. So you can see more of this fat is being stretched and pulled, and there's always some soft tissue that is overlying the lateral muscles. So let's come back to this cross section once again. Now you can see clearly now that you have essentially laterally been within the more visceral compartment. The reason you want to stay in the visceral compartment is because the nerves lie more superficial to the intermediate fascia that is present over there. You don't want the nerves to be exposed to any mesh that you place in this area for fear of chronic neuralgias. So how are we actually placing our meshes in some of these inguinal cases? We take down the intermediate fascia somewhere in the vicinity of the inferior epigastrics, and you land up placing a mesh that is deeper laterally or in the visceral compartment, while closer to the midline, you're in the most superficial compartment, which is the cave of the Retzius. You always want to have some fascia that is covering the nerves. In this picture, it's very apparent that there is a translucent fascia covering them. You can also appreciate blood vessels that run transversely across these nerves. This is just another picture with another nerve that's covered with fascia. Again, this is, in my mind, significantly going to reduce your chance of having nerve entrapment or chronic pain as a result of the mesh contracting over a period of time. Now, while we're on the subject of nerves, let's talk about the classic description of these nerves, which is what you see over here. The only nerve that passes above the iliopubic tract into the deep ring is the genital branch of the genitofemoral, whereas all the other three nerves, which are the femoral, the lateral cutaneous nerve of thigh, and the femoral branch of genitofemoral, all pass under the iliopubic tract. And that is true in most cases. But this is a great study by Ryan Pohl's group that did dissection in human cadavers in about 30 specimens, I believe, and they plotted the exact point at which the nerves were crossing the abdominal wall. This is the genital branch of the genitofemoral. Now, this is a map of the femoral branch of genitofemoral. And you can see in quite a few cases, the nerve has actually passed superficial or above the level of the iliopubic tract. This is the distribution of the lateral cutaneous nerve of thigh. And again, you can see the needle is actually marking the ASIS. And there are a few points at which the nerves have passed above this level. This is a patient with left-sided TEP repair who has significant pain. When you just take a simple pelvic radiograph and draw a line connecting the anterior superior iliac spine and the pubis, it's apparent that the two lateral tacks are actually underneath the level of the iliopubic tract. So this person has directly had tacks inserted within the triangle of pain, and that would explain the chronic issues. Now, remember, for safe lateral fixation, always ensure that you are able to feel the tip of your tacker across the abdominal wall. If you can't feel it by applying counter pressure, then, well, the tip of your tacker is actually going down below the iliopubic tract into the pelvis, and you can't fire it. It's a big no-no. Let's talk about where you would land up placing the mesh and how you'd fix it. So this is the myopectoral orifice of Flucho. It obviously involves the direct hernia space, the indirect space, as well as the femoral defect. Now, remember, the exact location of your mesh is going to depend upon what your intraoperative findings were. You always want to center your mesh well based on which hernia you're dealing with. So you may want your mesh to be slightly inferomedial for a direct hernia and slightly superolateral for an indirect hernia. And definitely you want a deep inferior extension if you're dealing with a femoral hernia. As per the concept of the critical view of MPO, the minimum recommended mesh size is 10 by 15 centimeters. You want some contralateral overlap. When it comes to fixing this mesh, choosing the first point of fixation at the Coopers is always easy and safe. For lateral fixation, I would advise you stay at least 2 to 2.5 centimeters above the level of the iliopubic tract. Now, remember, I showed you diagrams where the nerves were actually passing above the tract, so you want to avoid those. So I usually try to stay about 2 to 2.5 centimeters above that level just for some added safety. When you're dealing with pantaloon hernias, a very large inguinal scrotal or a wide direct defect, you can also land up performing a 3-point fixation. I would recommend fixing it really high up towards the superior edge of the mesh for added security. And of course, here there's no great anatomical structure apart from the inferior epigastrics that you need to be looking out for. I hope you have a great rest of the conference. Thank you so much.
That was a great talk on anatomy. Does anyone have any questions? Eham, do you ever worry, I'll ask a question, do you ever worry about the aberrant courses of the ilioinguinal, iliohypogastric when you're placing those lateral tacks? You might catch them on the other side.
Yeah, that's definitely a fear. And honestly, the more I read and the more cases I perform, I'm less and less convinced by tackers in that space. If I have to fix a mesh laterally, I'd rather take a suture bite. So I ensure I'm staying on the deeper side of the muscles. The real threat is to actually entrap a nerve that you can't see in the laparoscopic view. And that's a problem with the ilioinguinal and iliohypogastrics. And especially if you're looking at a tacker with a particularly long profile, you can end up damaging those as the tack goes across the muscles. And that's a problem. So over a period of time, I'm either letting go of lateral fixation altogether or I'm performing more suture fixations with PDS.
Eham, I have a question. What do you understand about femoral nerve injuries in posterior approaches to the groin hernia?
Well, they have, you're talking about the femoral nerve proper or the lateral cutaneous femoral nerve?
The femoral nerve proper. Is it important or is it not important?
It's not really important. I think I've personally never seen the femoral nerve myself. It's there in all of the diagrams. It's important important to know that it's just lateral to the vessels and you can definitely damage it. Overzealously parietalizing peritoneum or trying to take too many of the nodes off the great vessels, definitely don't try to look for it yourself. And injury to the femoral nerve is possible, but I haven't heard of anyone actually landing up doing that.
Okay, thanks.
Have you?
Well, there are reports. I have personally no experience about it.
I think we should move on to the next.
Yes.
Thanks so much.
Yeah, sure. Welcome.